Okay, hello again. Well, this is very special for me because it gives me great pleasure to introduce Ms. Marianne Khoury, who is a medical student at Case Western Reserve University here in Cleveland, Ohio. And I've known Marianne for many years. She was actually the FMD research coordinator for the registry I worked with a number of years ago before she went to medical school. And I'm very excited for her to give a presentation today. Spine disease among patients with FMD, is this an issue? Welcome, med student Khoury.
So a little bit of background, as we said, so FMD is an arterial disease that we know affects multiple vessels throughout the body. And there have been two studies that have aimed to examine if there are any non-vascular features associated with FMD. So the first one is the 2014 paper by Dr. Ganesh, which was a collaboration with the NIH and the NIA. And the second study was in 2015 out of the Cleveland Clinic with Dr. Gornick. And I'll go a little bit more into depth about what were the non-vascular features that were suggested to be associated. Mainly, we saw that dural ectasia was one, which is basically a ballooning of the spinal sac surrounding the spinal cord, and some high arched palate, dental crowding, nearsightedness, and some arthritis and degenerative spine disease. As we know that there are some other of these more classical connective tissue disorders such as Loeys-Dietz, Marfan syndrome, and vascular Ehlers-Danlos syndromes. And there have been some studies that have shown that there are non-vascular features associated with these connective tissue disorders as well, such as scoliosis and arthritis. And while we think that FMD does have some association and similarities to these connective tissue disorders, we do think it's still considered to be a distinct entity. And as Dr. Ganesh mentioned and other presentations will show, we're still in the works of trying to figure out any other genetic mechanisms underlying the pathophysiology of FMD. So a little bit more about the NIH study. The study had 47 women who had extensive imaging. They had spine MRIs, bone density scans, and brain imaging as well. And the findings showed that about 96% of the patients had degenerative disc disease. And then there were other orthopedic MSK type of findings as well. Dural ectasia was present among 42%. And about 30% of that patient cohort was found to have scoliosis. And then in the Cleveland Clinic study, 139 patients had data reported in the study. They were aiming to see if there were any connective tissue symptoms and features associated with FMD. They found that there was nearsightedness was one, a high palate and dental crowding, and early onset arthritis was common among patients with FMD. In this cohort, about 27% of the patients had scoliosis. And interestingly, the more typical common connective tissue disorders were not found to be associated with FMD. So coming to our study, what were our objectives and our hypotheses? So first off, we were aiming to determine the prevalence and the characteristics of spine disease among patients with FMD seen at a specialized referral center. And our hypothesis in regards to this was that we hypothesized that there would be a significant prevalence of spine disease among patients with FMD. Secondly, we were aiming to determine the clinical and vascular features associated with spine disease among patients with FMD. And our hypothesis in this regard was that we hypothesized that patients with a more aggressive phenotype of FMD would in fact have increased prevalence of spine disease. And we defined the aggressive phenotype as having at least one dissection and or having at least 2 aneurysms. And this was described as a high-risk vascular profile in the O'Connor paper in 2015. So how we did the study, we enrolled patients seen at our university hospitals in Cleveland FMD program. We had enrollment from April to November of 2021, and our setup was basically threefold. So first, we had a clinician questionnaire, which was Dr. Gornick would fill out to determine the FMD features. We had a patient questionnaire that had self-reported data fields across a bunch of different spine symptoms and other everyday symptoms that patients are experiencing. And thirdly, we had an imaging review component, and the imaging review component was collecting imaging data from any patient who had an FMD protocol, which we defined as brain to pelvis CTA, and as well as reviewing any dedicated spine imaging, which included X-rays and spinal MRIs. So This is a description of our cohort. So as you can see here, we had 144 patients whose data was reported for female at birth patients. The mean age of the enrollment was 61. You can see that we have a wide range of patient ages here from 38 to 86 years old. The mean age at diagnosis was 55. And then about 95% of our patients had multifocal FMD, with the most common vascular beds being the extracranial carotids and the renal arteries. About 28% of our patients had aneurysms, and about 30% of our patients had dissection. And then about 40% of our cohort had this aggressive phenotype. And this is more or less similar to the findings that have been shown from the FMD registry cohort. So as a result of these self-reported patient questionnaire findings, we asked a bunch of different questions about headache, back pain, injections, and you can see here that, excuse me, over 80% of our patients had back pain. And of those patients with back pain, about 45% of the patients had daily frequency of back pain, which is quite significant. And we see that about 77% of our patients had neck pain. And this is in contrast to about 22% of the patients who reported neck pain from the first 2012 paper of the first 447 patients of the registry. About 20% of our patients had injections for neck or back pain control. And we see that about 38% of our patients had a history of being diagnosed with either scoliosis, kyphosis, and lordosis, which are all different types of curvature of the spine. And about 10% of our patients had spine surgery, with the most common location being of the lumbar sacral area, which is the lower back. So we had statistical analyses performed and to test whether our hypothesis of if the aggressive phenotype is associated with increased prevalence of spine manifestations. And bottom line is that we really didn't see any significant association between the FMD phenotype and scoliosis, neck pain, or back pain, or a history of spine surgery, and you can see the statistics here. So what are our key findings? So one, we see that it seems that there is some type of signal among patients with FMD in regards to having a high prevalence of scoliosis, as about 38% of our patients have this reported history of being diagnosed with scoliosis. Secondly, we see that back and neck pain are quite common symptoms among patients with FMD, as over 80% of our patients had back pain, with 50% reporting daily frequency. And this is a little bit of a novel thing because we know that neck pain has been reported in the registry, and we think the most common symptom for, or the reason for neck pain among patients with FMD is dissection. But this back pain is something new that we're finding to be a reported common symptom. And then among patients, the average age of the survey was 61 years. And at that point, already 10% of our patients have already had spine surgery, most commonly of the lumbar and sacral region. And then like I said, we found no association between the aggressive phenotype and the scoliosis, back pain, or neck pain, or spine surgery. And this could actually suggest that there may not be a preference for the aggressive phenotype and the scoliosis. And in fact, it could be that the spine disorders and the severity of neck pain or back pain could be prevalent among all patients with FMD, regardless of aneurysm or dissection status. And lastly, the findings of the study so far show that we need to examine additional mechanisms of action that could be contributing to our patients' common symptoms of back pain and neck pain. So what are the next steps? What we're going to be doing next is that we're going to be working with Dr. Castlewall, who is our neurosurgeon, part of this study team, and we'll be reviewing all the imaging that I mentioned before, and we're going to be trying to quantify the degree of scoliosis, and we'll also be including assessment for any other spine-related disorders, such as degenerative disc disease, facet changes, spinal instability, Khoury malformation, which is where the cerebellum part of the brain is a little bit lower than where it should be. And then there will be another final analysis to determine maybe if on imaging review, as opposed to just a self-reported patient questionnaire, if there is an association with the aggressive phenotype of FMD with increased prevalence of the spine disease. So stay tuned to find out. And lastly, this is my acknowledgement slide. I want to thank Dr. Gornick, my PI and a dear mentor to me, Dina Jajanovic, and Nazla, who are our research coordinators, Rebecca Young, who is our nurse, for the FMD clinic. And an additional thanks to Dr. Manish Kaswal, who's our neurosurgeon, and Dr. Narav Patil, who was our statistician. And thank you to Pam Mason, FMDSA, for having me. It's been an honor and a pleasure to be able to speak with you today. Thank you.
Thanks, Marianne. That was great. Nice job. Let me ask you, can you define again for me what aggressive FMD is?
Sure. So per the 2015 paper, defined aggressive phenotype as having at least one dissection and or having at least 2 aneurysms.
Okay. We have a question here that it says, both of my parents have back neck pain and arthritis in the back and spine. Should they be tested for FMD?
So I'm going to say not necessarily. We see that there might be an association, but it might be more so one-sided, that patients with FMD have an increased prevalence of spine disease rather than everybody that has arthritis has FMD. So unless they would have other more classical symptoms, especially high blood pressure, maybe err on the side of caution there.
Okay. A number of all of my patients have neck pain, and of course they worry about, is this a dissection or not that they're having, especially when they have exacerbations of their neck pain. So maybe you or Dr. Gornick could tell me how you guys handle that. Do you send them for a CT angiogram every time somebody complains of neck pain, or what do you do?
Dr. Gornick, do you want to take this?
Sure. Yeah, I think it's really tough, especially in patients with prior dissection. And I think usually we are on the side of, if there's any concerns, we get imaging. But I also eventually come to this point with patients, and Jeff, I'm sure you're there too, where people just kind of learn their body and they sort of know, is this my usual kind of neck pain I've had for years that's flaring up, or is this something different? And then definitely neck pain with other neurologic symptoms like loss of vision, weakness, numbness on one side of the body. I guess if the swooshing all of a sudden gets suddenly worse, then you're going to want to image. But it can be really tricky because I think dissection is a big cause of neck pain in our patients. But I think based on the 2 prior studies and our series, I think there is something going on with musculoskeletal back and neck pain in our population. Jeff, I don't know if you just anecdotally have any comments on these data and what if it fits with what you've seen clinically.
I do, but first I'd like to tell you, I have really severe neck pain. Do you think I should be tested?
I wish I could fly over to Manhattan, get my stethoscope, and do my exam.
Anyway, yeah, it seems like everybody has neck pain. But so in your study, Marianne, what was the control group? Was there a control group? No.
We don't have a control group yet. We, in the final analysis, what I think we would like to do is be able to see a general population, the prevalence of scoliosis in the general population, and compare that to our cohort.
Yeah, I think that's very, very important. Before we say that FMD patients have much greater likelihood of spine and neck problems, it would be important to have an age and sex match control group to really answer that question.
Exactly.
And someone asked here, how do these results compare to the rest of the population? For example, most patients over the age of 50 would have degenerative disc disease to some extent. I agree with that completely.
I agree. I think, our rates of scoliosis are a little higher than national averages. We'll see, obviously this is very preliminary. And the rate of surgery may be a little higher. 9-10% seems a little high for a group of women in their 50s. But again, I think very preliminary, and mainly just with this data, we want to just keep this topic alive. Is FMD, does it have extravascular manifestations? And hopefully inspire other groups to also look at this rigorously, as you said, Jeff.
The other thing is, like, how many people actually look for scoliosis in their patients? I mean, I can say personally, before you guys started doing this, and before I started seeing a lot of this, I would make the diagnosis of scoliosis when I got a CT angiogram in the chest, abdomen, and pelvis, and I'd see the spine is like really curved, but I wouldn't have made it clinically. So it makes me wonder, how often that diagnosis is being made in the general population. Let's see. Heather, is there anything you want to add to this? Is there any association with this with osteoporosis?
So I think in the Dr. Ganesh paper, in the Dr. Ganesh paper in 2014, the bone density scans, if I recall correctly, there was a significant percentage of reduced bone density, but whether this is due to FMD specifically or age-related factors, that I don't remember exactly.
Okay. Yeah, just another question about neck pain and headaches all the time. Does that mean my FMD is progressing? If I can just interject here, I did not have time to show this in my talk, but my colleague, Dr. Katie Dodoff, and our group published a paper on lack of progression of carotid FMD, where we followed a number of patients for many years, and no patient had the presence of beading in an arterial segment that wasn't present to begin with, so no anatomic progression. 3 patients over the follow-up had a dissection, and 2 of those 3 patients had a previous dissection. So it's very, very unrare to see progression of carotid disease.
Well, Jeff, do you think we should wrap it up? It's 1:05. I think Marianne, thank you very much. We think the future is bright. It's great to see medical students interested in FMD. And
I can retire now, Marianne.
Dr. Olin can retire now, Marianne. I don't know if you heard that. Well, actually, she has to finish residency and fellowship so she can take your practice in New York and join Dr.
Yeah, give me a few more years.
Got a few more years. All right,
Heather, back to you.
All right, thank you for joining us, Dr. Olin. We are now going to take another 15-minute break. Coffee break, and then we will be back at 1:20 promptly to continue the program with Dr. Kovacic, and then we're going to have our grand finale, all the questions you would ever want to have answered about FMD at the end. So we'll see you back in 15 minutes.